Imagine treating liver cancer, arthritis, maybe an enlarged prostate, all with just a simple pinhole incision, no surgery, almost no recovery time. Well, it's reality now. And we want to talk about what's going on at Emory with Dr. David Prologo, Division Director of Interventional Radiology at Emory and Winship Cancer Institute. Doc, it's great having you on this morning.
Thank you so much for having me. I appreciate it.
I'm going to need you to make this simple for me, if you can. So let's just start with, what is interventional radiology?
So thank you for asking that question.
Okay.
So interventional radiology is a specialty that most people don't know about. And it gives us the ability to manage these things you mentioned: arthritis, enlarged prostates, degenerative disc disease, so many things, cancer, without any surgery, without any cutting, without any pills, without any opioids, without any implants. It's all done. I have my prop
Let's
here.
see it, please.
It's all done. We just make a small puncture and we put this rubber tube, it's hollow. And we just sort of work our tools through here, and when the procedure's done, we take it out, we put a Band-Aid over that, and send you home.
So what kind of conditions can this treat right now?
I think the most exciting one is osteoarthritis, arthritis in the knees. We'll use that as an example. 30 million people with this condition. It's inflammation, right? And so before interventional radiology, or without interventional radiology, maybe you get a big surgery and get a knee replaced, or maybe even worse, you get opioids and narcotics and all the terrible downstream things associated with that. But instead, we can work through this thing, and we can block the blood vessels that are abnormal and are inflamed, and we can stop the progression of the disease.
Wow.
So if I get one tomorrow, I have some arthritis in my knee, it's not going to get any worse because we're getting at the underlying problem without anything other than this and some fancy imaging guidance.
Okay, remote robotic endovascular technology. Walk us through what that actually looks like. I mean, what's the doctor doing in the room? Is the doctor in the room? What is the patient experiencing?
So this is the evolution of interventional radiology. So we think about these procedures and these conditions that we can treat through here. And now what we've done, we've got a huge advantage here in Atlanta because we have Emory.
Yeah.
And we've got an interventional radiology division that is innovating and evolving and pushing the edge of the technology. So to answer your question, I have one more problem, which looks sort of like a game console that we have here. And we can work the tools through this same thing we call a sheath using this remotely. So if somebody is 10 feet away from me, or hopefully very soon miles away from me, we can do the case without having to stand next to the patient and be in the room, and we can do it with exquisite precision.
You said hopefully soon miles away from me. What do you mean by that?
So Emory being the first in the world to do these endovascular robotics cases locally, we are also the ones who are working on the technology to allow us to do this in Macon from Emory University Hospital.
Why is that so important for this moment when we hear so often about rural hospitals closing?
So we are in a time when rural and under-resourced populations in and around Atlanta are not, they don't have the same access to healthcare and the same access to complex procedures that others do. And so it's important for the healthcare system in the United States to acknowledge that these human beings need these same procedures, but may not be able to travel all the way here. So what we are developing is the technology to be able to treat them with the same minimally invasive and cheaper techniques, but from a distance.
All right, you got my attention when you said cheaper. Is this something insurance is covering, and how much cheaper are we talking about for the patient?
Absolutely, and the cost differential is dramatic. We are talking about the difference. If we use the prostate example, if we can shrink your prostate with that same day before noon and go home process, compare that to staying in the hospital for 3 or 4 days, the cost differential is quite significant. And all of these other downstream things that happen if we don't use a minimally invasive process. For example, one of the things we treat degenerative disc disease. We can do it in the same way using our imaging guidance, small punctures. We can have people out of pain. The alternative, if we compare both cost and what we call morbidity, which is the suffering of the patient, the alternative is either a big surgery, which you stay in the hospital for and recover from for weeks, or you leave with pain medications and all of the downstream effects from that, which I mentioned before. So there's a big differential between coming in and having one pinhole placed, a procedure done under image guidance, leave at noon, versus these other options.
Let's talk about the recovery time in all this. Let's say I have a prostate procedure. You use this robotic technology. How soon could I be back at work?
I'm so glad you asked this question because we recently had a story in the AJC actually about this. We had a great patient who allowed us to tell his story that will be the answer to your question. He was an ex-police officer, a very active person, and he underwent what we call prostate artery embolization, which is this procedure we're talking about in interventional radiology. And he's a hockey goalie, and he was in a championship game 2 days later.
Wow, playing hockey 2 days after having this
Exactly,
procedure.
and I think that's a great illustration of the difference.
Okay, I'm trying to think of the downsides. I mean, are there any? How much more precise is it doing this than maybe by hand?
Oh, so the precision is 1 millimeter. So it's even hard to imagine. We can use these imaging guidance and these robotic techniques in 2026 to target any place in your body down to 1 millimeter precision. And that becomes important in another space, which is sort of close to my heart, and that's the advanced management of pain now.
Okay.
We can reach a pain generator in your body. Maybe it's from cancer, maybe it's from a degenerative disc. We can reach it with this technology with such exquisite precision using either robotics or the imaging guidance or a combination that previously was unavailable to us. So it's extremely precise.
I'm curious to know. Right now, it's able to treat liver cancer, arthritis, and large prostates. What you highlighted right now. But what conditions are next? I mean, looking down the road 5-10 years.
So I think the biggest difference we've made now, and what will also be the greatest explosion going forward, is the management of pain. Either related to cancer or not, because the tools that we put through this thing, they can do things like freeze and kill cancer, for example. Another big thing we do is freeze and shut off the signal from nerves that are carrying either a painful signal from a tumor, for example, or another pain generator in the body, or the nerve itself might be damaged. And so that's where the explosion has happened, and that's where I see the greatest impact happening going forward as well.
When you were in medical school, did you ever think you'd be able to hold the answer to people's pain in your hand on a TV set?
Oh my gosh, I can't imagine how the world has gone, and I often reflect on how I ended up in this position. But I'll tell you, the greatest difficulty we have, the greatest obstacle we have, is getting this word out. People don't know this exists. People don't know that we can do this. I meet a patient every week that I could have helped 18 months ago. And particularly at Emory. So this interaction is super helpful, and I hope a lot of people hear this, and that's where I thank you for your help.
So you're struggling to get the word out. I mean, how? All right, so hopefully we can let patients in the Atlanta area know about this, but what about the medical professions out there?
So my colleagues in other specialties are aware, and they're our biggest source of referrals now. For example, we have, of course, as you know, the Cancer Hospital, Winship Emory Midtown, which is just a beautiful 18-floor cancer-dedicated hospital, and the folks there, patients come to the hospital because they have too much pain to manage at home. And if you can imagine that that's your relative, you can imagine that you want them to get all of the attention and all of the technology available, right? But the people who work in that building, they know. And so they call us, and we take care of those people as if they were our own relatives.
Dr. David Prologo from Emory, thank you for being here. Any final word today?
Oh my gosh. We promise that if you come to Emory, we'll work as a team to solve your problem. We'll never cut you loose to figure it out on your own.
Thank you, sir. Fascinating conversation. Come back anytime.
Thanks.
All right.